what guardrails would you want in place before using an AI-driven HER2 low classifier to change treatment decisions, such as offering or withholding antibody drug conjugates?
Um, that's a good question. Let me think about that for a second. I think the ideal cutoff for identifying a patient for HER2 ADC is going to be one that has some type of predictive value. And so far, we don't actually even know if HER2 low, like the low end of expression range, the ultra low, sorry, is predictive compared to HER2 non-expressing. We don't actually have a sufficient group of patients with HER2 truly zero versus HER2 ultra low to know if at that low end of the HER2 expression range that identifying those HER2 ultra low cases more accurately will allow us to better select patients for treatment. And so ultimately what I would like to see, I'm not sure if we'll ever have this, is a comparison of these stratifications by different modalities and potentially different vendors. There was another interesting study recently published in Modern Pathology that had that compared many of these commercially available HER2 immunohistochemistry softwares and found that they can perform accurately, but there's actually a lot of discrepancy when you compare one software to another. And so the question is, what is the gold standard? Is it a pathologist assessment? There's a lot of inaccuracy between pathologists. Could you use some alternative biomarker like mRNA? But I think that for patients and as a clinical oncologist, the thing that matters most is, can you identify the patients that respond to the therapy and what is the best tool to stratify patients who would respond or who wouldn't respond? Um, right now, since I'm in favor of, I want to have the most number of shots at goal for a therapy for a patient. I guess I would want to have an assay that's going to be the most sensitive to allow me to at least have the therapeutic option for drugs like Enhertu for the most number of patients. And so I would want to make sure that the assay was at least as sensitive as kind of our pathologists. But we currently don't use these tools in our clinical practice. We have great breast pathologists in our program. And so I think it would require some data really showing that we can use this to improve selection of patients for treatment for me to adopt it.